Good evening, doctors. So we will be starting today's class, and if I'm not wrong, we'll be discussing the ECG and arrhythmias. So before we start with the arrhythmias, let's just start with the basic ECG first. So there is important thing to understand that basically ECG has everything that you need to understand the physiology that is built up behind the arrhythmias. So to begin with, this is the heart, and this is the right atrium. This is the LA. This is LV, and this is RV. So here is the SA node. This is the SA node. This is the AV node, and this is the his bundle. So when the wave travels from SA node to AV node, we have a P wave. This is atrial depolarization, and then there is some delay here, and then it becomes QRS here. And then the repolarization is the T wave, as you can see in the ECG drawn here. So we understand that there is a P wave, then there is a PR interval, which is the time taken for the wave to travel from the atria to beginning of the ventricular depolarization. The QRS complex itself is the ventricular depolarization, followed by the relaxation phase, that is the ventricular repolarization, leading to a T wave, and any distance between them is the ST segment. So that is what defines the normal ECG. And then what we see here is that for us, the P wave is important. P wave has to be followed by a QRS with, of course, a PR interval. And then the QRS has to be followed by a T wave with a QT interval. So these are the major things that are required to understand the whole of the ECG and the arrhythmias. Now, if I have to define the arrhythmias, if the sequence goes like the PQRST, that is PQRST, if this is the sequence, then it is called a sinus arrhythmia. So I always try to tell my students that when you are looking at an ECG, you should follow it just like the algebra model of mathematics. Instead of looking at the ECG like this, you should look at it like this. So once you are doing this, for example, let us say what you have, that you don't see a P. Then you can, by looking at the ECG, you can just write that there is a QRST, QRST. So that means now you understand that there was no P wave. So whatever is happening at the level of just before the QRS. That means the ECG is beginning at AV node and then it is following. Hence the QRS, because it is generating its own wavelength, hence it is a broad QRS at that point of time. So if there is a PQRST, then it is called a sinus arrhythmia. And sinus arrhythmia means there will be P, there will be QRS, and there will be T, but it will be the rhythm will be different. That means it can be fast, it can be slow. So sinus bradycardia, sinus tachycardia, these are the sinus arrhythmias. They can happen with normal respiration also. So for true and false question, you can get. So normal variation is there. And in fact, with, let us say, with beta blockers, with calcium channel blockers, with ivabradine, with digoxin, with all of these drugs, you can actually bring down the heart rate by inducing a sinus arrhythmia. Now, sinus bradycardia is basically, bradycardia is whenever the heart rate is less than 60 beats per minute. And you have to define that there is a P wave before every QRS. That means there is a relation between PQRS. The causes of sinus bradycardia are physiological, are increased vagal tone, pathological are thyroid disorders, and then iatrogenic causes are drugs like beta blocker, digoxin. Environmental causes are hypoxia, and then another disease condition is myocardial infarction with right coronary artery or maybe inferior valve. If you want to treat, when do you treat? When the bradycardia is associated with either syncope or pre-syncope or with hypotension. Otherwise, you do not treat sinus bradycardia. So all you need is, maybe you can just make the patient to run, give them a sympathetic stimulus, and this is all you can do. And if the patient is symptomatic, you can try atropine or even temporary pacing. Now coming to sinus tachycardia. So sinus tachycardia is a regular rhythm with rate more than 100 beats per minute. There has to be a P wave before every QRS, which is a defining criteria for sinus rhythm. Physiological causes would be exercise, stress, fever. Pathological causes would be anemia, hypothyroidism, cardiac failure, certain drugs like LSD, amphetamines, deriphyllin, theophylline, thioxanthines, all caffeine, all of them can cause tachycardia. The treatment is to treat the underlying cause. Okay, so this was the sinus tachycardia. Now, when we talk of arrhythmias which are not in the sinus rhythm, that means they are different from the sinus rhythm. The top of the chart comes supraventricular arrhythmias. That means they begin in the supraventricular portion. Then there will be ventricular arrhythmias which begin in the ventricular portion. So right now, let's focus on the supraventricular arrhythmias. In the supraventricular arrhythmias, there will be atrial fibrillation as the king of supraventricular arrhythmias. So the ECG finding will be number one, no P waves. No P waves. Number two, QRS is irregular. RR intervals. So second is RR interval is irregular. So irregular rhythm, no P waves, fibrillatory baseline, variable PR interval. Causes are hypertension. The biggest cause is age more than 65. So more than 65 years of age, around 30% of the normal population will have atrial fibrillation. Hypertension, coronary artery disease, heart failure, very important. Valvular heart disease. Which valvular heart disease? Rheumatic heart disease with mitral valve involvement, because this will lead to enlargement of the LA. Hyperthyroidism because of hypermetabolic state. How it can complicate? It can complicate by thromboembolic events. So these patients can have stroke, heart failure, digital gangrenes, renal failure, infarctions. So all of them can happen. Mesenteric ischemia, all of them. Why? Because if the heart is not pumping, fibrillation is atrial fibrillation, means atria is not contracting. So atria is not contracting, so it is not pushing the blood into LV because during aortic atrial systole, basically there is no atrial systole happening. You have to understand that there is no atrial systole because there is no P wave. So what's happening is that the atria is just fibrillating. Now a fibrillating atria is like a washing machine. So in the washing machine, it is a circulatory motion. So that circulatory motion will only make clots in the blood. Those clots will be kept here in the left auricle. So at the time of embolism, these thrombi, they move from LA to LV, and from LV they are pushed into aorta to reach either the brain or any other organ, leading to thromboembolic events. So these patients have to be calculated on Chadwick score and anticoagulation be started. What is the management? Management, see, there is no much difference as the data goes between rate control and rhythm control. However, if it is an acute atrial fibrillation, young patient, you should always aim at bringing the patient's heart rate back to normal sinus rhythm. Why? This is my question to everyone. Why should we try to aim to bring a patient of atrial fibrillation back into normal sinus rhythm? Give me 1, 2, 3 reasons. Anyone? Anyone?
So that heart can pump normally.
So number one is atria can pump normally. Heart is pumping. Ventricular pumping is basically heart pumping. So that, and what will help? How the atria pumping will help?
because there will be no collection or that emboli in the atrium. That is less chance of forming emboli in the atrium.
Okay. So there is something known as atrial output. When we are discussing the cardiac output and cardiac cycle, so 20% of the cardiac output is given by
Yes,
the atrial
given by
kick.
the atrial peak. Yes,
Yeah. So that atrial kick will be absent in patients of
atrial
atrial
fibrillation.
fibrillation. So if you can get them back into normal sinus rhythm, this patient can go into a good atrial contribution of 20%. So that means one, cardiac output will be stabilized. Number two, as you said, there will be lesser chances of clot formation. Number three, there is something known as tachyarrhythmia associated cardiomyopathy. So people who are continuously in increased heart rate, no, even if they have a thyroid disorder, it is not thyrocardiac disease, it is known as. But in general, anything that leads to a persistent tachycardia can lead to heart failure by causing tachyarrhythmia or tachycardia associated cardiomyopathy. So when we are controlling the heart rate or even the rhythm of a patient who has atrial fibrillation, we are trying to prevent them from going into tachycardia induced cardiomyopathy. Is that okay? So these are the major three reasons why we want to bring them back to cardiac rhythm. Number one, it is a physiological rhythm. It contributes 20%. And that is why a patient who has a normal ejection fraction will not land up into heart failure because of atrial fibrillation. Imagine somebody whose EF is 30 to 35%. Out of that EF, the stroke volume, 20% is being contributed by the atrial contraction. Imagine if that also doesn't happen, these patients will go very rapidly into heart failure, pulmonary edema, because they cannot sustain a loss of cardiac output due to lack of atrial contribution. Is that okay? Then comes the strangest murmur. Oh, strangest arrhythmia. Oh, what is wrong with my pencil? So that is known as atrial flutter. Again, a supraventricular arrhythmia. What distinguishes it from atrial fibrillation is a regular QR, a regular RR interval. And instead of a fibrillatory baseline, it has a proper baseline known as sawtooth appearance, basically formed by lot of P waves clustered together, out of which only few can go. So this is atrial flutter. So this is SA node, or this is some abnormal aberrant atrial ectopic points. So they are all firing at AV node. Obviously, AV node cannot conduct all of them. So AV node will conduct one or few of them. So it is defined as this is one P wave which is traveled. Then there is one, one, two, one, two, three. So this is a atrial flutter with variable AV block. So this is a physiological phenomena of AV block. Why? Because if a P wave falls on the AV node during the refractory period, the absolute refractory period, it will not conduct. So all the atrial flutters, they have an inherent block in them that controls the heart rate, because flutter is very fast otherwise. So you will see a sort of pattern in flutter. The heart rate should be around 300 and above, and regular and rarely variable ventricular response. Cause is some re-entry circuit. Somebody who's sitting closer than the SA node and is firing repetitively on the AV node. Management is similar. So which are the drugs that are indicated in atrial fibrillation and flutter are A, B, C, D, E. So A is amiodarone, B is beta blockers, C is calcium channel blockers, D is digoxin, and E is electric shock. Okay. So when is electric shock given? It is the rule of thumb in any arrhythmia.
Hemodynamic instability.
With hemodynamic, very good, instability. So this is atrial flutter. Now coming to another important supraventricular arrhythmia is supraventricular tachycardia. It is a very common arrhythmia. We have a narrow QRS complex. P waves may be buried inside or they may be falling. I mean, P wave can come before, P wave can come after, P wave can be buried in the QRS complex. So all three are possible. Usually due to AVNRT, that is AV nodal reentrant tachycardia. So basically, AF was when atria is not contracting, it is fibrillating. Flutter is when somebody closer to the AV node is causing a re-entry circuit. SVT is when the re-entry circuit is either extremely close to AV node or it is in the AV node itself. So it is like running here only. And it can throw P wave backwards, known as retrograde P wave. That can also be there. Or antigrade P wave, or a P wave which is embedded inside the QRS. They are all supraventricular arrhythmias. Point to be noted is that there will be regular QRS, regular RR interval and a narrow QRS. Why narrow QRS? Because it is happening in the AV node or just proximal to AV node only. Now, rarely you can have an SVT with aberrancy. What is aberrancy word? Aberrancy means that it is not a normal pathway through which the things are being conducted. And the disease is known as WPW syndrome. So what happens is, here is the AV node, here is the SA node, and this is the his bundle. Imagine there is this point here, and it is conducting from this pathway directly to his bundle via bundle of Kent. So what is happening is it is actually bypassing the AV node, and this is the re-entry circuit that is established from that ectopic. But the problem is that it is delivering its current directly to his bundle, hence the QRS will be broad. So you will have a broad QRS tachycardia with a regular RR interval, and usually these patients are not in shock, they are not hemodynamically unstable, but you will have to define those patients as not having a ventricular tachycardia because they look just like ventricular tachycardia. So they are basically AVRT, where it is due to Wolff-Parkinson White syndrome, WPW, where there is an aberrant pathway leading to a broad QRS complex. So that is known as SVT with aberrancy. That can happen with atrial fibrillation also. So normally supraventricular arrhythmias are defined by a narrow QRS complex. That doesn't mean that they cannot be present with a broad QRS complex. It is only that it becomes a little complicated. So it is aberrant from the normal. That is why it's known as SVT or atrial fibrillation with aberrancy. Then you will need to define it, that because the drug will change. In ventricular tachycardia, you will prefer giving xylocaine IV, but in case of SVT or atrial fibrillation with aberrancy, although it will have broad QRS complex, you will prefer myodrone, digoxin, beta blocker, calcium channel blocker, and all these. Now the treatment for SVT, because I told you these patients usually are hemodynamically stable. It is one of the most benign arrhythmias. Everybody comes to the hospital. Nobody crashes and comes to the hospital, unlike other arrhythmias. So SVT can walk into your hospital. So vagal maneuvers, adenosine, beta blockers, calcium channel blockers, long-term prevention can help with catheter ablation. So you can actually burn that area which is throwing SVT. Now that we have done with the supraventricular major arrhythmias, let's discuss ventricular tachycardia. Now, ventricular tachycardia is defined by ventricular origin of the arrhythmia, number one. Number two, the QRS will be broad because now these are out of the picture. It is this only. Either this is the focus or this is the focus. Somewhere here, the focus is there and they are throwing back the arrhythmia. Hence, these patients have a monomorphic, one-dimensional running rhythm. QRS is broad, more than 120. Regular rhythm is there and no P waves because it suppresses the AV and the SA node. Most common reason is coronary artery disease. Second is cardiomyopathy. Third is electrolyte imbalance, for example, potassium issues and magnesium issues. What is stable VT? Stable VT is when the patient comes to you with QRS widening and they have a good pulse, BP of around 110. So they are very good patients to be treated. So stable VT, you give a myodrome, they revert back. You give beta blockers long, they are perfectly fine. You open up the blood vessel, coronary artery disease, absolutely fine. Unstable VT, you need to do immediate cardioversion. And pulseless VT, because there is no pulse, there is no QRS. So cardioversion is not the term used, although method is same, it is defibrillation. So immediate defib, pulseless VT, unstable VT, stable VT. And then there is big brother of ventricular arrhythmias. Major cause of sudden cardiac death worldwide is ventricular fibrillation. ECG shows irregular chaotic baseline. You cannot define anything. You cannot say this is P wave, this is QRS. This is just jig, 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 jig. And the patient is gasping, patient is cyanosed, patient does not respond, patient is literally dead, only the heart is fibrillating. So immediate shock, DC defibrillation, immediate defibrillation, because you cannot have a ventricular fibrillation with stable hemodynamics. सवाल ही पैदा नहीं होता. These patients, the ventricle is responsible for pulse generation, and here the ventricle is fibrillating like a washing machine. So there is no pulse. So immediate CPR plus defibrillation, immediate defibrillation. And if the patient is not responding and you have ECMO support, put the patient on ECMO and try to salvage the patient if they are neurologically intact. Another type of ventricular tachycardia is torsades des pointes, which is also known as polymorphic VT like saregama. Saregama is, so this is the classical picture of Saregama logo, that is Indian company which makes music. So this is what happens. That is torsades des pointes. Usually patients collapse, sudden cardiac death. Immediate treatment is defibrillation plus IV magnesium. Magnesium sulfate and defibrillation if unstable. Okay, so basically there is twisting of the QRS complexes around the baseline. That is what's called dancing. Torsades des pointes. Usually the causes are prolonged QT interval, either due to drug induced like beryllium and other drugs, or due to some
congenital
long QT syndrome, congenital, or Brugada syndrome, or is also there, which can throw the patient into this torsades des pointes. And one more thing, nowadays you might be noticing that the ACLS, from the ACLS protocol, thumb version has been removed. People used to tell that you just with your fist thump the sternum. Earlier VT was, there was this recommendation that you can use the thumb. Now it is abolished because sometimes when you give the punch to the chest of the patient can develop torsades des pointes. Okay, just a second. Hello. Hello. गुड आफ्टरनून जी. हाँ जी, जल्दी दसो, मैं क्लास ले रहे. हाँ जी हैं. मैं बाद चो करदा गल. Yeah. So now coming to the blocks. So block is when the normal SA node, AV node, his bundle, there is some block somewhere. So the road is blocked. So the flow is blocked. Flow of the wave is blocked. So what happens is, as it gets low, the PR interval becomes prolonged. So the PR will be prolonged. Regular rhythm That means P is followed by QRS and there is no wave between. If it is, then it is something else. I'll tell you what it is. This is first degree heart block. Increased vagal tone, beta blockers, calcium channel blocker, digoxin, hypothermia, calcium issues, potassium issues, all of them can cause. Typically, no treatment is needed. These are usually hereditary. In fact, some sportsmen, they always have it because of the increased vagal tone. First degree heart block. Second degree heart block is something very interesting. Now, what happens is in second degree heart block, the P wave which had to be conducted, it conducts to be a QRS at a slower pace in number 1, still slower pace in number 2, and sometimes it can in fact go on to drop a beat only to start again. This is called Wenke-Bach phenomena. Now, Wenke-Bach phenomena, you can remember that it is Mobitz type Wenke-Bach. One key back. So Mobitz type 1 is having Wenke-Bach phenomena where there is a progressive PR interval until one of the QRS will be dropped. So there is a drop beat. However, in Mobitz type 2, there is no fixed correlation. What happens is there is a constant PR interval which suddenly there will be a drop beat. See, constant. You cannot predict when it will happen. And the PP interval can also not be predicted. And during this time, patient may collapse, known as syncope, only to get okay again. Why? Because then one P wave will be conducted and the patient will have a pulse and they will wake up. But because these can lead to collapse of the patient, this becomes an indication for pacing. So Mobitz type 2 is an indication for pacing. Wenke-Bach is not. First degree heart block is not. Then comes complete heart block or third degree AV block. In third degree AV block, there is no relationship between the P and the QRS complexes. So the P wave is running at its own pace. QRS is running at its own pace. So there is no relationship. Can occur due to RCA occlusion because 80% of the world's population, RCA gives the SA node and AV nodal artery. So if the RCA is blocked proximally before the origin of these vessels, they can go into third degree AV block. It is also known as complete heart block. Treatment is initially TPI, temporary pacing, followed by coronary angiogram and opening of the vessel, and then permanent pacemaker insertion. These are the summary of different AV blocks. You can see here, this is first degree AV block, where it is a fixed PR interval, slow but fixed. Second degree type 1, PR interval is constantly prolonging until one beat is dropped, then again the same cycle starts. This is called Wenke-Bach phenomena, Wenke-Bach. Then is type 2, Mobitz type 2, second degree. So we cannot predict when a pulse will be dropped. So this is type 2. Advanced 2:1 AV block is when every second beat is conducted and third is dropped. So one is conducted, one is dropped, one is conducted, one is dropped, one is conducted, one is dropped. Advanced 3:1 is one is conducted, second is not conducted, third is not conducted, fourth will be conducted. 3:1. Complete AV block is where P waves are running at their own pace. So they may come after the QRS, or they may come before the QRS, or they may not come at all. So this is complete AV nodal blockage. Very beautifully defined here. So this is the tachyarrhythmia framework for you. You can remember this. You can keep this photo with you. You can take a snapshot. So tachyarrhythmia framework means all you do is make this 4 chambers, write regular rhythm here, irregular here, and narrow QRS up and wide QRS. So Narrow and regular is sinus tachycardia, AV nodal, orthodromic AVRT, atrial tachycardia, atrial flutter, junctional tachy. Wide QRS, regular rhythm, VT, SVT with bundle branch block, antidromic AVRT means WPW, pre-excited SVT, again WPW. So these are the wide QRS, that means SVT with aberrancy. Now, irregular rhythm by definition is atrial fibrillation or atrial flutter with variable AV block, because whenever AV block will be conducted, it will lead to a pulse. QRS is the pulse. Always remember, P wave is not the pulse. Multifocal atrial tachycardia can also have irregular narrow complex because these are supraventricular. Then comes wide QRS and irregular polymorphic VT, that is torsades. So again, irregular wide QRS. AFib with bundle branch block or atrial flutter or atrial fibrillation with aberrancy, that is WPW syndrome. Again, they can have wide QRS with irregular rhythm. Okay. So I have something very important for you to show. We will do WPW syndrome. So WPW syndrome is, I have already told you that there is an accessory pathway, which is a pathway known as bundle of Kent. So that bundle of Kent, it allows the signals to bypass the AV node and directly stimulate the ventricles, leading to pre-excitation. Pre-excitation means this will follow the normal course. But if somebody is pumping the waves through this channel, then obviously there will be no PR interval, nothing. So what you will see is a P wave literally climbed upon QRS every time. So there is a short PR interval. PR is less than 120 ms. Okay. So leading to pre-excitation. This predisposes to arrhythmias like AV nodal reentrant tachycardia. So ECG will be short PR interval due to early ventricular activation through accessory pathway. Delta wave will be there, a slurred upstroke by the QRS, because the ventricle also was not expecting that a wave will come and I have to contract beforehand. So that is why that is called pre-excitation of the ventricles. Again, because it is conducted directly, the QRS will be broad, and let us say the pathway is entering into the left ventricle. The right ventricle will be conducted late because it is going from ventricle into other ventricle. So this patient will classically have a right bundle branch pattern. Imagine somebody having a aberrant pathway from AV atria to the right bundle, right ventricle. Then these patients will have a wave that conducts to the left ventricle later. So they will have a LBBB pattern. So these patterns will be there whenever you see a aberrant pathway, and then you can even define that which side it is coming from. So these are the findings that you see. These are the findings that you see. So this is classical, that the P wave is literally overriding. The P wave is overriding into the QRS. So there is a short PR interval. And then there is a something known as delta wave, which is hidden here. And then there is some ST segment changes like ST sagging and all. They will be there. Here you can appreciate it much better. The P wave is here. It literally crosses over, and then there is a delta wave, and then so you see PR interval is short, and then there's a delta wave. Type of arrhythmias you will not need. They are more cardiology specific, but this is how the things are happening here. But they usually, if you can see, these are orthodromic and antidromic. So basically what happens is when it is going orthodromic PSVT, it will be rapid, regular, narrow QRS because it is entering into the AV nodal pathway only. Whereas antidromic pathway, look, this literally looks like a VT, doesn't it? This antidromic PSVT. Anybody can get confused over here. A rapid, regular, wide QRS complex tachycardia with retrograde conduction via AV node. These are the most dangerous ones because if you give these patients will need shock and they might degenerate into VT and the access will change. So many things happen here. Atrial fibrillation with with aberrant pathway, this is how they look. So people will confuse this to a VT when actually it is just an atrial fibrillation. Atrial fibrillation with aberrancy, with aberrant pathway. Now I have kept a specific ECG for atrial fibrillation with WPW. So here you can appreciate that in WPW, there will be definitely rapid ventricular rates because the accessory pathway conducts without any AV nodal restriction. So irregular rhythm with wide QRS complexes. And how can you define that this is not a VT? Because you can obviously impressively find out a delta wave here. Can you see the delta wave here? On the sagging segment, on the descending segment, you can see a delta wave here. So you can actually say that this is atrial fibrillation with aberrancy. Okay. So what is the management? Basically, the management will be first line in unstable will be defibrillation. For stable patients, amiodarone can be used, beta blockers, anything ABCD can be used, but eventually these patients will need catheter ablation. So that is the end of the treatment, that is catheter ablation. Now coming to a problem known as long QT syndrome. So in normally QT interval is less than 360, 380, but we can keep it up to 450. When it goes up to more than 440 in males, more than 460 in females, we call it prolonged QT interval. Of course, it can be drug induced or congenital. So it can, why we are bothered? Because it can have a R on T phenomena. That means the T becomes so far away that the next QRS R may fall on this T and torsades will happen. So torsades will happen. Hence, what we need is beta blockers like propranolol or mexiletine. Although mexiletine also is notorious at higher doses, it can also lead to QT prolongation. But these patients will require a defibrillation implantable. This is the clinical approach. You need to have a history and a good pedigree analysis. Ask for the family history, parents, father, grandfather. Get an ECG. Try to find if the easiest way to define QT syndrome is that you flip this page and try to place RR on each other like a card, like a birthday card. No, you flip it over, and if the center line crosses through the T wave, it is a QT is prolonged. That is the easiest way of defining QT prolongation. Okay, so all you try to do is just fold the paper, ECG paper, and try to keep R on R. And when you keep the R on R, what will happen is the QRS, the T wave will be in the center. So that helps. So if the patient has a history of cardiac arrest or cardiogenic syncope, then you should avoid the drugs and put them on beta blocker like propranolol, or do a ICD or damage the vessel. Brugada syndrome is not asked to MRCP candidates usually, but if you want, I can tell you it basically is that ST elevation is there in V1 to V3 with bundle branch pattern. So that is Brugada. It's basically a genetic mutation. So what you see is normally we see that patients have this kind of a pattern. ST elevation is there. So this is Brugada. So V1 to V3 ST elevation. Many times these patients are thrombolized. Why? Because of the ST elevation. So, but the problem is that these patients can have a sudden cardiac arrest. So Brugada syndrome leads to ECG changes, and in MRCP part 1, you will not get ECGs. It is only for MRCP part 2 that they might give you ECG with Brugada syndrome. Problem is with sodium channels leading to this depolarization changes. ICD will be required. So this is classical Brugada. You can see there is a pattern, RBBB pattern with ST elevation in V1 to V3. Immediately after V1 to V3, dust seems to settle down. There is no changes anywhere else. It is only in V1 to V3. So there will be this kind of a picture. The T wave will be inverted, ST will be up, and it will be RBBP pattern. Is that okay? So can we take up the questions now? Okay. So a 68-year-old man presenting with palpitations and dizziness. His ECG shows a narrow complex tachycardia with no visible P waves and blood pressure is stable. What is the best initial treatment for this patient? Anyone? So can you define what kind of an arrhythmia is this?
SVT, sir. Stable SVT.
So patient has a normal complex tachycardia with no visible P waves, and the patient has a
no
visible P waves, and his BP is stable. So there is no P wave. The BP is stable.
I think it is atrial fibrillation. No, irregular heart is not there.
Yeah. So we have not mentioned anything, but we have clearly mentioned that this patient has narrow complex tachycardia with no visible P waves. So that could very well be SVT. And as I told you, the patient will walk into your room. So this patient has a SVT, and we will be trying to treat them with adenosine, which is the drug of choice of the management of SVT. Is that okay?
Yes.
So unless it is, because I told you, in SVT, one can see the P wave preceding QRS, built into the QRS, maybe following the QRS, but if the rate is very high, you may not see the P wave, but it's a regular tachycardia. And usually the patients are hemodynamically stable. Okay. Now, question number 2. A 60-year-old man is admitted with severe chest pain radiating to his left arm. Now his ECG shows ST elevation in lead 2, 3 and AVX. So what do you make of it?
The inferior wall MI.
So you think it's an inferior wall MI. So what is the most immediate step in the management of this patient?
Immediate percutaneous coronary intervention.
So this patient should be taken up for what kind of a disease is this? How do you define this disease? It is known as inferior wall STEMI. Yes. So what is the management of STEMI? It is immediate percutaneous intervention. So this patient has inferior wall STEMI. All right. So there will be mixture of all the ECGs here. A 45-year-old woman with history of long QT interval presents after a syncopal episode. Her ECG shows polymorphic VT consistent with this tachycardia. Torsades this point is. So what is the most appropriate initial treatment?
Magnesium sulfate.
So immediately what you will give is?
Magnesium sulfate, 2 grams.
So you will give magnesium sulfate immediately. And if the patient is broad collapsed, then if the patient has pulseless, then?
Cardioversion.
Then cardioversion will be the treatment. So magnesium is the immediate treatment. Next question. A 78-year-old woman presents with worsening fatigue and lightheadedness. Okay. Her ECG shows a PR interval of 250. What is the most likely diagnosis? So normal PR interval is how much?
120 to 200.
So 120 to 200, and here we have more than 250, and ECG shows PR interval of 250. No other mention is there. Worsening fatigue and lightheadedness. What is the diagnosis?
Second degree.
Why second degree? Why? Why not first degree?
PR interval is not prolonged in first degree.
How do you define first degree heart block then? So first degree heart block is defined as a regular, prolonged, fixed prolonged PR interval. Second degree Mobitz type 1 is progressive prolongation.
Okay.
Second degree type 2 is when you cannot predict the prolongation. Third degree is obviously all different. I have not drawn QRS, but I have just drawn PP for you. So what is the answer here? Come on. It is first degree heart block. Okay?
Okay.
All right. Next question. A 52-year-old man presents with syncope while exercising. ECG shows ST elevation in V1 to V3 along with right bundle branch block pattern. There is no prior history of cardiac disease. What is the diagnosis?
So Brugada, as you have told now, just now.
Very good. So you will not miss this diagnosis now, not even in the clinical practice. Okay. So this is Brugada unless proven otherwise. Okay. ST elevation in right precordial leads V1 to V3 and right bundle branch block pattern. So the treatment is ICD plus beta blockers, of course. Okay. Okay. So we have this question now. A 55-year-old man coming with palpitations, discomfort in the chest and shortness of breath. ECG shows irregular rhythm with no P waves, variable RR interval. Oh, what is the diagnosis?
AF.
So diagnosis is atrial fibrillation. What is the most appropriate long-term management strategy for stroke prevention?
Warfarin or direct oral anticoagulant.
Yeah, so you calculate the CHA2DS2 score and then you start the patient on warfarin or direct oral anticoagulants. Okay. So this patient has high incidence of stroke. All right. So a 65-year-old woman with history of CAD comes to the emergency after experiencing syncope. Her ECG shows wide complex tachycardia 180. Oh my God. So QRS is too broad here. What will you do? What is the diagnosis?
Torsades dependencies.
Wow. Why? QRS is fixed at 180. Torsades you cannot make out. This is a fixed 180.
Monomorphic VT.
Yes. So this is a VT. And the patient has syncope. What will you do?
Synchronized cardioversion, unstable monomorphic VT.
Yes. So this patient needs synchronized cardioversion. Okay. And then take the patient up for what? Coronary angiography.
Yes.
Okay. 72-year-old woman comes with dizziness and near syncope. ECG shows progressive prolongation of PR followed by a sudden drop in QRS complex. What is the diagnosis? Hello. What is the diagnosis?
Second degree.
Mobitz type 2, sir.
Her ECG shows progressive prolongation. When the word progressive comes, what is it?
Type 1, sir.
When keyback phenomena.
But drop is there.
Eventually it will drop. This is what has. I'll take you to the ECG.
Sir, please clear it.
Yes, this is what I'm going to do. Where are the bradycardias? Where are the bradycardias? Here are the bradycardias. So, type 1, where is the type 1 block? Okay. Type 1 is fixed QR, fixed PR interval prolongation, 250 ms. Okay.
But no drop is there.
C drop. Here it is the drop.
Okay. So drop may be there. Okay.
No, it will be there.
Oh, it will be there. Okay.
So this is basically tolerance. What happens is the QRS tolerates the PR interval. It tolerates. The tolerance gives away. P only comes, and then again the same cycle starts. So there is a giving up issue. So one QRS will give up sometime. When you can predict when the QRS will not come, this is Venki-back phenomena. When you cannot predict when it will drop, then it is a type.
That is type 2. Okay.
Yes. Okay.
Okay.
So it is all with the prediction. If you can predict, that's a different thing. But if you cannot predict, then it is Venki-back phenomena. Okay.
Thank you. Thank you.
So this is Mobitz type 1. The problem is that both of them are second degree. So you have to remember that in first degree heart block, it is a fixed PR prolongation. In second degree heart block, you must remember there is a dropped QRS. If you can predict when it will,
unpredicted.
then it is first type 1, and 1 is 1 key back. You can remember it like that.
1 key back.
Okay. Second type is when you cannot predict.
Thank you, sir.
Okay.
Yes.
So in first degree heart block, it is a fixed PR.
Okay.
In second degree heart block, there is a dropped QRS. When it will be dropped, if you can predict it, then it is a first type. If you cannot predict it, then it is second type. How can you predict it? Because there is a progressive. So progressive, predictable.
Okay.
Okay.
Okay. Thank you.
Yeah. So this patient has a progressive PR interval prolonging. That is known as Venki-back. So it is Mobitz type 1. Okay. A 60-year-old woman, man, presents with chest pain radiating to left arm. ECG shows ST elevation in lead V2 to V4. Which artery is occluded?
V2, V4.
Left anterior descending.
Left anterior descending.
Yeah. So if I have to, okay, I'll ask you some difficult question that I taught you in the last class. I'll ask. So this is circumflex territory.
Yes.
This is V4 to V6. This is V1 to V4. Is that okay?
Yes.
Yes.
So if there is any thrombus here, now what will happen here if the thrombus is here? This is the left main.
Okay.
Where will be the ST elevation? I told you in the last class.
B7.
So in AVR, classically there is a P wave inverted and T wave inverted, AVR.
Okay.
But in case of left main coronary artery thrombosis, the upright P will be there and ST elevation will be there in the AVR with ST depression.
Yes.
In V4 to V6.
V6.
Okay. I'll show you.
Yes, you have told in the last class.
Yeah. So it is left main occlusion ECG. Okay. So can you see?
Yes.
So now this is ST elevation here in AVR and V4 to V6. What is happening? ST depression and T wave inversion. Yes. This is the classical combination for left main occlusion. And believe me, this question was there in MRCP exam. That there was a patient who came to the emergency with chest pain and STEMI, and because nothing was available, the patient was thrombolized. Suddenly, the nurse noticed that the patient is having chest pain again, and there was ST elevation in AVR. What is the likely diagnosis? The first answer was the ECG leads are incorrectly placed. So that can also happen. That P wave can become upright and T wave become upright and wrongly placed ECGs, and that happens in AVR only. But for a patient with ST elevation and then V4 to V6, ST depression and T wave inversion, it is sudden left main stenosis. Patient will die if you don't treat this patient. Okay. So this patient has LAD territory because V2 to V4. Okay. Now we have a patient who is a 40-year-old woman with history of palpitations with ECG showing delta wave, a short PR interval and a wide QRS complex. So palpitations hai, ECG है, delta wave है, short PR है.
WPW.
So this is
WPW, sir. Very easy.
WPW syndrome. Okay. So this is WPW syndrome. Next question. A 45-year-old man comes with palpitations and chest pain. ECG shows a wide QRS with a M-shaped R wave in lead 1, V5 and V6. What is the likely diagnosis? So yeah, very good. So it has to be remembered like V1, V6. So it is MARROW and William. So V1 will have M pattern in RBBB. V6 will have W pattern in V6 in RBBB, and V1 will have W pattern in left bundle branch in V1 and M in V6. Is that okay? Easy?
Yes.
Yes, sir.
So in this case, M-shaped R wave in V5 and V6. So M-shaped R wave in V5 to V6. So that is left bundle branch block. Okay, easy. Cool. Oh. Okay. Okay. This patient, 30-year-old young boy, coming with palpitations. ECG shows a short PR interval, wide QRS complex, and a delta wave. What is the definitive treatment option? Definitive.
Catheter ablation.
So
WPW.
you will burn up the accessory pathway.
Okay.
So catheter ablation. "50-year-old man with COPD comes with dyspnea. ECG shows a wide QRS complex with RSR pattern in V1 and wide S wave in lead 1. What is the most likely diagnosis?
RBB.
Right bundle.
So this has right bundle branch block secondary to COPD. Why RBBB? Physiologically, there will be cor pulmonale. So the right ventricle will be dilated and the current will need long way to cover right ventricle. So right bundle branch block will develop. Okay. A 28-year-old female comes to emergency with palpitation. ECG shows a narrow QRS with tachycardia 180. Vagal maneuvers done but unsuccessful. Hemodynamically okay. What will you do next?
Adenosine.
Yeah, young female, narrow QRS, likely PSVT. Treatment is adenosine. Treatment is adenosine. Okay. First, 62-year-old man comes with chest pain, shortness of breath. ECG shows ST elevation in V1 to V3, RBBB pattern. What condition is it?
Brugada syndrome.
Very good. Now the students are very fast in identifying Brugada. Very good. Good. And what will be the treatment?
Beta blocker.
Or?
ICD.
ICD.
Thank you. So this was ECG and arrhythmias. But we are not finishing here. We are finishing the topic today. Which topic? Very important. DVLA guidelines for cardiac patients. Now, very important. It will definitely 2 to 4 questions will come from DVLA for cardiac patients. So whenever you see a patient in your OPD, think that if this patient can be danger to anyone else while they are driving. So you have to classify the patient in either they are driving for themselves or they are driving for people. So they will be divided into group 1 and group 2. Okay. So group 1 is private vehicle, self. Group 2 is public vehicle, bus, truck or something, train even. If the patient had an ACS like MI, non-STEMI, STEMI, unstable angina, no driving if patient was treated conservatively, means you could not do any angioplasty on the patient, no bypass surgery. Then these patients have high risk of arrhythmia in next 4 weeks. So you will not do it. 1 week if PTCA was done, if angioplasty was done. For group 2, 6 weeks off. These patients cannot drive. Patient will need a re-license if the patient has more than 40% EF, no angina, and passes a treadmill test. These are the guidelines for patient who has had an MI. For patient of heart failure, they can drive if they are NYHA class 1 or class 2 maximum with no syncope. A patient of heart failure with ref is not allowed if symptomatic, if not allowed if EF is less than 40. Very clear. Pacemaker, no driving for 1 week post-implantation, and group 2, no driving for 6 weeks. ICD implantation, permanent restriction from public driving. Absolutely. A patient who has had an ICD, if the ICD battery goes down, then the patient can die and kill everyone around. But can drive for no driving for 6 months for VT or secondary prevention for a patient who drives for themselves. Atrial fibrillation and SVT, give medication, no restriction, can drive a well-controlled even for public vehicle. Aortic aneurysm, if the size is less than 6.5, can drive. More than 6.5 centimeter, a public driver cannot get a license. Valvular heart disease, symptomatic, no license. But for personal driving, can do. Syncope, no driving for 6 months if unexplained. If the patient is high risk, 1 year off from job. Hypertension, no restriction if the BP is less than 180. For public driving, BP has to be less than 180 by 100. Otherwise, below 180 by 100. Otherwise, no license will be given. Now, we will do the MCQs directly. A 55-year-old lorry driver. Just a second. Can you read the question, please? Someone? Anyone?
A 55-year-old lorry driver had an anterior ST elevated MI treated with primary PCI. His left ventricular ejection fraction is 38% and he is asymptomatic. He asks when he can return to work.
What will you suggest? He's a lorry driver. He's STEMI treated with PCI. So when do you advise him to go back to work?
So they have
Post MI.
Yes.
Primary PCI done. So we have cleared the patient with stenting. So we will just, what is happening? So let's see here. How many off? It is the first line.
40% not allowed.
So, abhi to patient has, after 6 weeks, EF will be checked.
Okay.
So he will need a reassessment, but when can he return back?
After 6 weeks.
After 6 weeks. Wonderful. So answer is after 6 weeks. No book you will find these questions. These I have prepared specifically for MRC.
Sir, just wait. I'll take
Yes.
a snapshot.
You need a snapshot?
Yes, sir. Just wait.
I will send you the whole PPT. Don't worry. I will send it to Sana and she will give it to everyone. Don't worry.
Okay.
Okay?
So then, okay.
Yeah. Okay. So for group 2, that is lorry driver, driving is restricted for 6 weeks post MI. A treadmill test and LVEF 40% are required before returning. Since his EF is 38%, he may need an assessment before clearance. He might need a relicensing. Okay. A 48-year-old man with paroxysmal atrial fibrillation controlled on beta blocker experiences near syncope. What is the driving restriction for private driver? So he was drug controlled but has a near syncope, becomes symptomatic. So how long? I will take you back to atrial fibrillation.
No symptom. No driving for 6 months.
Okay.
So because this patient had a pre-syncope, so we would restrict him to drive for 6
6 months.
months. Okay.
Okay.
So no driving for 6 months. Unexplained syncope requires 6 months off for group 1 and 12 months off for group 2 drivers unless a cause is identified. A 67-year-old bus driver had an ICD implanted for secondary prevention. He's a bus driver. ICD is implanted.
पैर तो नहीं टूटेगा ना, अब हम नहीं बैठेंगे.
He asks when he can resume driving. Yes.
Permanent disqualified.
Permanent disqualified. Wonderful. So anyone with ICD, no driving. Chapter closed for them. Because even if he gets a shock, he can black out for a moment. And in that meanwhile, he can fall into a cave. Okay. 59-year-old private car driver with stable angina requires an elective PCI. How long should he refrain from driving? Private car.
4 weeks, sir.
4 weeks.
1 week for group 1. 4 weeks for group 2. Sorry, 6 weeks for group 2. I'll take you again. No driving for 4 weeks if treated conservatively. 1 week for successful angioplasty. So how many days?
1 week.
Angioplasty हो गया patient का.
जी sir.
Elective PCI. How much?
1 week.
1 week. So 1 week. After successful elective PCI, driving can resume after 1 week. Okay. A 72-year-old man is found to have abdominal aortic aneurysm of 6.6 centimeter on routine screening. He is asymptomatic and drives a taxi. What is the DVLA's rule on this? He is a public driver. More
No
than
license.
6.5 centimeter. I'll take you to page 1 again.
No license.
Yes. 6.5
More than
and above.
6.5.
No license. So he cannot have a license. Must stop driving immediately. Okay. A 50-year-old HGV driver with hypertension has a BP of 170/95 on medication. What should we advise him? Should he continue to drive? Should he stop driving until his BP is less than 180?
Yes, sir.
Permanently qualified. Already it is less than 180/100, no? 170/95.
Yeah,
So can he continue to drive?
we can continue.
Yes. So there is no fear. We can tell him that you can continue driving as per DVLA guidelines. Okay.
Yes.
A 62-year-old man with severe aortic stenosis remains asymptomatic. He drives a commercial vehicle. What should be the advice here? No restriction, can drive, stop driving, undergo valve replacement, stop driving indefinitely, continue driving if symptomatic. So he has a
Stop
tight
driving and
AS. gradient is more than 40, which becomes a symptomatic AS. Although the patient is asymptomatic, maybe because of some reasons, but it is a severe AS, less than 1 centimeter square. So this patient needs AVR urgently, because this is the time when he can be taken up for valve replacement. If the LV starts to fail, then it will not help if we do his valve replacement. So he should stop driving immediately and undergo valve replacement. Is that okay? Group 2 drivers with severe AS must stop driving. They can return post-surgery if they meet fitness standards. Okay? A 42-year-old private car driver with first-time seizure is diagnosed with long QT syndrome. Iski to ho gayi chutti. When can he drive again? So seizure or syncope, basically. Identified cause. So diagnosed with long QT syndrome.
Never, sir.
So ideally it should be never, but because he's a private car driver, the guidelines are that he can drive after 12 months. Okay. Seizure का ना actually 1 month, 12 months. So patient should be, for group 1, first seizure requires 12 months of driving, but if it is a syncope, he can drive after 6 months. But then here he has a long QT syndrome, a very technical question. I think this patient should immediately be referred for an ICD insertion, and post ICD insertion, this patient should be taken up for after 6 months. This is the ideal situation. I think this question needs reframing.
Yes.
Yeah. Okay, I'll do that. A 68-year-old man with dilated cardiomyopathy drives a taxi. His EF is 38%. He is NYHA class 2. What is the correct DLA advice?
Private car.
So he should stop driving because EF is less than 40%, and he is a public driver. So he is a, must stop driving. So he's a, for group 2, LVEF below 40% means disqualification. A 50-year-old HGV driver presents with VT but remains asymptomatic. ICD is planned. When can he drive after the ICD implantation?
6 weeks, sir.
Never.
He is a Sarkari man. He is a public driver.
Permanent restriction.
He can never drive, because if an ICD gives him a shock, he can become blind suddenly, have a blackout, and then he can kill everyone around. Okay? I will send this to Sana. So these are major type questions that you will get in DVLA. So the first, this chart, DVLA keeps on, changing the guidelines. These are from 2024, if I'm not wrong. You can also check it online, and you can download this. And there is a Neurowala also, DVLA guidelines for neurological conditions. You should also download that as well. Okay? Any questions?
We have cleared already.
Yeah, so we have finished the cardiology. In case there is anything which is left, you can drop the message, but I think we've covered everything now. Everything is finished. Thank you for your patience and bearing. And Sana, let me know about the next class then. And if there is any feedback, any more questions you need, I have a lot of big question bank in case you need anything. Okay. All right.
Sure,
Take
sir.
care.
Thank you, sir.